Okay, let's dive right into a really fundamental concept. Immunity. It's the system that decides if a common cold is just annoying or, well, something much more serious.
Right, and when it breaks down significantly, the body's just left wide open, vulnerable.
Absolutely. And our source material today really zooms in on probably the most stark example of that vulnerability, HIV, human immunodeficiency virus.
And specifically how it can progress to AIDS, acquired immune deficiency syndrome, which is technically stage HIV-3, that advanced stage of immune failure.
So our mission here is to give you a clear, concise guide through this. We'll walk through the pathophysiology, the stages, testing, and importantly, the nursing care, all based on the chapter material.
Exactly. Think of it as a quick but thorough tour of HIV disease management, start to finish, focusing on what you need to know for care.
Okay, before we get deep into the mechanics, let's just nail down three key terms from the text. First up, retrovirus. What makes HIV a retrovirus?
Well, retroviruses are sort of unique. They carry their genetic code as RNA, not DNA. And the tricky part is they have an enzyme that lets them rewrite that RNA into DNA.
Which then gets inserted right into the host cell's own DNA. Super sneaky.
Precisely. Masters of integration. Then there's viremia.
Which just means basically, can we detect the virus in the person's blood? Is it actively circulating?
Yep. Simple as that.
Yeah.
And finally, a term that's really crucial for understanding advanced disease, opportunistic infections, or OIs.
Ah, yes. The infections that usually don't cause problems because a healthy immune system keeps them in check.
Exactly. They're often caused by microbes that are already living on or in us, part of our normal microbiome.
Right.
But when immunity drops, especially those CD4 T cells, these normally harmless bugs can become really dangerous, even fatal.
Got it. Okay, so let's unpack how HIV, this retrovirus, actually causes all this immune system chaos. It specifically targets the CD4 plus T cells, the helper T cells. Why those cells in particular?
Because the CD4 cell is like the quarterback of the immune system. It directs almost all the other immune responses. So taking it out basically cripples the whole defense strategy.
How does it actually get inside that specific cell?
It's a very targeted process.
Yeah.
The virus has these surface proteins, GP120 and GP41. GP120 first docks onto the CD4 receptor on the T cell surface.
Right.
But that's not enough. It also needs to bind to a second receptor, a co-receptor, which is usually either CCR5 or CXCR4. Think of it like needing two keys to unlock the door.
I see that dual binding.
Right. Once both are engaged, the GP41 protein basically harpoons the cell membrane, pulls the virus in, and fuses, allowing the viral RNA and enzymes to get dumped inside the T cell.
And that very specific binding process is where some of our drugs work, right? Like the fusion inhibitors and CCR5 antagonists.
Exactly. They're designed to block those specific steps, either jamming the CCR5 lock or preventing that final fusion step. Stop the virus from even getting in.
Okay, so let's say the virus gets in. What happens next inside the T cell?
So now the viral RNA is inside. But to take over, it needs to become DNA to integrate into the host's genome. This is where the enzyme reverse transcriptase, or RT, comes in. It reads the viral RNA and synthesizes a DNA copy.
The step that makes it a retrovirus?
Precisely. Then another viral enzyme, integrase, takes that newly made viral DNA and literally snips the host cell's DNA and inserts the viral DNA right into it.
Wow. So at that point, the T cell is essentially reprogrammed.
Completely. It
Okay.
stops being an immune cell and becomes an HIV factory, churning out new virus particles, which then bud off to infect more CD4 cells.
And our other major drug classes target these steps too, right? The NRTIs, NNRTIs, and the integrase inhibitors?
Yep. NRTIs and NNRTIs both disrupt the reverse transcriptase enzyme, stopping the RNA to DNA conversion. And integrase inhibitors, well, they block that integrase enzyme, preventing the viral DNA from getting woven into the host DNA. It's a multi-pronged attack on the replication cycle.
Which brings us to the stages of the disease. It's described as a continuum. Stage I is the acute stage.
Right. This happens usually within, say, 2 to 4 weeks after infection. The viral load skyrockets, lots of virus in the blood. People often get symptoms, but they're very nonspecific.
Like flu symptoms, fever, maybe a rash, sore throat.
Exactly. Often mistaken for the flu or mono. The key thing here, though, is that because the viral load is so high, the person is extremely infectious during this short phase, high risk of transmission.
Then it moves into stage 2, the chronic stage.
Correct. This used to be called the asymptomatic or latent phase, but chronic is better. With today's treatments, people can stay in this stage for many, many years, even decades.
And their immune system is still relatively functional during this time?
Relatively, yes.
Mm.
The virus is still replicating, usually at lower levels, and the CD4 count is gradually declining, but often not low enough to cause major symptoms. So a lot of people get diagnosed during this stage.
Until eventually, without treatment or if treatment fails, it progresses to stage 3, AIDS.
Yes, and it's important to be precise here. You're diagnosed with AIDS, or stage HIV-3 if you are HIV positive, and D, you meet one of two criteria.
Okay, what are they?
Either your CD4 plus T cell count drops below 200 cells per cubic millimeter. The normal range is usually like 800 to 1200 OR. You develop one of those specific AIDS-defining opportunistic infections we mentioned earlier, regardless of your CD4 count.
So less than 200 CD4 cells or R and OI equals an AIDS diagnosis.
Correct. And a really important point the source makes. Once you have an AIDS diagnosis, that diagnosis stays with you for life for classification purposes, even if your CD4 count goes back up above 200 with treatment.
That's a key detail. It reflects the history of severe immune damage. Okay, let's shift gears to how HIV is actually transmitted. What does the source emphasize here?
The big message is always what it's not transmitted by. Casual contact is zero risk. So no transmission from hugging, shaking hands, sharing toilets, dishes, or even insect bites like mosquitoes. That's really important public health messaging.
So where is the risk? What are the main routes?
There are three main routes. Sexual contact, that includes genital, anal, or oral sex, where infected fluids like semen, vaginal secretions, or blood come into contact with mucous membranes or breaks in the skin.
Okay, sexual. What else?
Second is parenteral transmission. That mostly means sharing contaminated needles or syringes like with injection drug use. Or, much rarer now, through contaminated blood products, though screening has made that incredibly unlikely in developed countries.
And the third.
Perinatal transmission, from mother to child. This can happen during pregnancy across the placenta, during childbirth, through exposure to blood and fluids, or afterwards through breastfeeding.
The source mentions a specific safety priority regarding sexual transmission risk.
Yes, it highlights that anal intercourse, receptive anal intercourse, specifically carries the highest risk statistically.
Why is that?
Because the rectal lining, the mucous membrane there, is thinner and more fragile than, say, the vaginal lining. It's more easily torn during sex, creating direct entry points for the virus into the bloodstream.
That makes sense from an anatomical perspective. And what about who is most affected? The demographics have shifted over time.
They have. While HIV affects all groups, the source notes that currently in the U.S., the burden is disproportionately higher among certain populations. This includes men who have sex with men, MSM, people who inject drugs, and particularly racial and ethnic minorities like Black African Americans and Hispanics.
The text also mentions increasing incidence in the transgender community and poor outcomes often seen in women.
Right. Poor outcomes for women are often linked to factors like later diagnosis, maybe lack of access to care, or specific socioeconomic challenges. It's complex.
Okay, let's talk prevention. This area has seen huge advancements. What are the key strategies now?
Well, the absolute game changer is UU. Undetectable equals untransmittable.
Explain that one.
It means that if a person living with HIV is on effective antiretroviral therapy and their viral load has been consistently suppressed to undetectable levels, usually defined as less than 20 copies per milliliter for at least 6 months, then there is effectively zero risk of them transmitting the virus to a sexual partner. Zero. It's a massive step forward for reducing stigma and encouraging treatment.
That's incredible. What else? We hear a lot about pre-P.
Yes, pre-BP, or pre-exposure prophylaxis. This is for people who are HIV negative but are at high risk of getting infected. They take specific antiretroviral medications every day to prevent HIV infection if they are exposed.
Usually drugs like Truvada or Descovy, right? But the source flags a drug alert here.
A critical one. First, adherence is key. You need to take it consistently. It takes about 7 days of daily use to reach maximum protection levels in blood and rectal tissue, maybe longer for vaginal tissue. Missing doses compromises protection.
So consistency is crucial. What else?
Regular monitoring. Because these drugs can potentially affect kidney and liver function, people on pre-PP need lab tests every 3 months. And crucially, they need regular HIV testing too.
Why the regular HIV testing?
Because you absolutely must confirm the person is still HIV negative before starting or continuing pre-P. If someone unknowingly has acute HIV and starts pre-P, they're essentially getting suboptimal treatment, which can quickly lead to the virus developing resistance to those drugs.
Making future treatment much harder.
Got it. So that's pre-exposure. What about after a potential exposure?
That's PEP, post-exposure prophylaxis. This is used after a known or suspected high-risk exposure, maybe a needle stick injury for a healthcare worker, or unprotected sex with someone known to have HIV.
What's the protocol?
It involves starting a combination of antiretroviral drugs, usually 3 drugs, as soon as possible, ideally within 2 hours, and definitely within 36 hours of the exposure. Waiting longer significantly reduces effectiveness.
And how long do they take PP?
It's a 28-day course of medication.
Okay. And for healthcare workers specifically, what's the main risk and the best prevention? The primary risk is occupational exposure through needle stick or other sharps injuries. And the absolute best prevention, stressed heavily in the source, is a consistent use of standard precautions with every patient, regardless of their known or suspected infection status. Treat everyone's blood and body fluids as potentially infectious.
Universal diligence. Okay, let's shift to clinical signs. When immunity really starts to fail in stage 3, what clues should we be looking for? The source lists key features of AIDS.
Yeah, it breaks it down by system. For the skin or integumentary system, you might see things like really dry skin, poor wound healing, persistent skin lesions, and often drenching night sweats.
And gastrointestinal.
That's a big one. Chronic diarrhea is very common, leading to weight loss. Nausea, vomiting, loss of appetite, all contributing to malnutrition.
What about the nervous system?
Also heavily impacted, you can see CNS effects like confusion, memory loss, progressing even to dementia, sometimes called HIV-associated neurocognitive disorder or HAND. And peripheral neuropathy, that tingling or pain in the hands and feet, is also quite common.
But the real hallmark of AIDS, as we said, are the opportunistic infections. Let's touch on the major ones mentioned.
Top of the list often is pneumocystis jirovecii pneumonia, or PCP. It used to be called pneumocystis carinii. This is a fungal infection of the lungs.
What does PCP look like clinically?
Usually shortness of breath, maybe a persistent dry cough that doesn't go away, low-grade fever, fatigue, the major threat to gas exchange.
Okay, PCP. What else is common?
Candidiasis, which is a yeast infection. It's often seen as thrush, those white cottage cheese-like plaques in the mouth or throat. If it extends down into the esophagus, it's called candida esophagitis, which makes swallowing incredibly painful.
Really impacts nutrition then.
Hugely. Then there's tuberculosis, TB.
Hmm?
People with HIV are at much higher risk for TB, and it can often be more severe or spread outside the lungs, what we call extrapulmonary TB.
And you mentioned a diagnostic challenge with TB earlier.
Yes, the concept of anergy.
Hmm.
Because the immune system is so weak, the person might not be able to mount a reaction to the standard PPD skin test for TB.
So a negative PPD doesn't rule out TB in someone with advanced HIV.
Exactly. It can be falsely negative. That's a huge safety concern.
So what's the nursing priority if TB is suspected in someone with HIV?
Immediate airborne precautions, in addition to standard precautions. You have to assume they could have active infectious pulmonary TB until it's definitively ruled out. Faster tests like the NIAT, the nucleic acid amplification test on sputum, are crucial here.
Don't rely just on the skin test. Okay, one more major O I mentioned is a cancer.
Yes, Kaposi sarcoma, or KS. This is actually caused by a type of herpes virus, HHV8. It used to be almost synonymous with AIDS visually.
What does KS look like?
It typically appears as purplish-brown, raised lesions on the skin, mucous membranes, or sometimes internal organs. They can be small spots or larger tumors. It's a significant issue for tissue integrity.
Okay, so we know the signs. How do we confirm the diagnosis and monitor the disease? Lab tests.
Right. Basic lymphocyte counts are usually affected. You'll often see leukopenia, which is a low white blood cell count overall, and specifically lymphocytopenia, a low lymphocyte count.
But for specific HIV diagnosis, there's a new standard algorithm.
Yes. The CDC recommends the 4th generation HIV assay. This is a big improvement.
Why is it better than older tests?
Because it detects 2 things: HIV antibodies, which the body produces in response to the virus,
Yeah.
and the P24 antigen, which is actually a protein component of the virus itself.
And the P24 antigen shows up earlier.
Much earlier.
Yeah.
Usually detectable around 14 days after infection, whereas antibodies can take 21 days or longer to show up. So this 4th-gen test significantly shortens that window period where someone could be infected but still test negative. Faster diagnosis means faster treatment.
That makes a huge difference. And once diagnosed and on treatment, how do we track effectiveness?
That's where viral load testing comes in. This test measures the actual amount of HIV RNA particles in a milliliter of blood.
So it tells you how much virus is actively replicating.
Exactly. The goal of treatment is to get the viral load down to undetectable levels, typically less than 20 copies per milliliter. That's the key measure of treatment success, alongside monitoring the CD4 count to see immune recovery.
Okay, this leads us nicely into management and care. It sounds like it really requires a team approach.
Absolutely. The goal is maintaining the highest possible level of function and quality of life for as long as possible. That involves nurses, doctors specializing in infectious disease, registered dietitian nutritionists, social workers, pharmacists. A whole interprofessional team is essential.
And from a nursing perspective, what's the top priority according to the source?
Preventing infection is paramount, both preventing the patient from acquiring new infections due to their weakened immunity and controlling the HIV infection itself.
Let's talk about controlling the virus first. The main tool is drug therapy, right? CART.
Yes, CART, which stands for Combination Antiretroviral Therapy, sometimes just called ART. It involves using a cocktail of drugs, usually 3 or more from different classes, that attack the virus at multiple points in its replication cycle.
And it controls the virus, but doesn't kill it.
Correct. It suppresses viral replication very effectively, often to undetectable levels, which allows the immune system, specifically the CD4 cells, to recover. But it doesn't eradicate the virus reservoirs hiding in certain cells. So it's a lifelong treatment, not a cure.
Lifelong treatment means adherence is critical. How critical?
Extremely. The source emphasizes this is probably the single most important factor for success. Patients need to take their medications exactly as prescribed, on schedule, at least 90% of the time.
90%. Why such a high threshold?
Because HIV replicates so rapidly and makes mistakes, meaning it mutates easily. If drug levels in the body dip because doses are missed, the virus can quickly develop mutations that make it resistant to those drugs.
And once resistance develops,
That drug, and often others in the same class, become ineffective for that person, potentially forever. It drastically limits future treatment options. So that 90% adherence is really the minimum needed to keep the virus suppressed and prevent resistance.
that's a huge teaching point. Now, you mentioned something earlier, a complication that can happen when treatment starts working well, iris.
Yes, IRIS.
Yeah.
Immune reconstitution inflammatory syndrome. It's a bit paradoxical.
How does it work?
When CART starts working and the CD4 count begins to rebound quickly, the recovering immune system suddenly wakes up and recognizes opportunistic infections that were already present but weren't causing obvious symptoms because the immune system was too weak to react.
So the immune system overreacts.
Exactly. It launches a strong inflammatory response against these previously hidden infections like maybe underlying TB or fungal infections or CMV. This can cause a temporary worsening of symptoms, fever, swollen lymph nodes, worsening signs of that specific infection.
That must be alarming for the patient. How is it managed?
Usually by treating the underlying OI aggressively, and sometimes short-term corticosteroids are needed to dampen down that excessive inflammation from iris itself while continuing the CART.
Okay, besides managing CART, what are the key nursing strategies for that priority of preventing infection, especially OIs? What do patients need to know for self-management?
A lot of patient education is involved. Basic hygiene is crucial, frequent hand washing. They should avoid large crowds or people who are obviously sick, especially during flu season.
What about specific exposures to avoid?
Definitely. Don't share personal items that could have blood on them, like razors or toothbrushes. Food safety is big. Avoid raw or undercooked eggs, meat, poultry, or fish due to risks like salmonella or listeria.
And the source mentions pets.
Yes, specifically avoiding cleaning pet litter boxes if possible, because cat feces can transmit toxoplasmosis. Also, avoid contact with reptile pets like turtles or snakes due to salmonella risk. Careful handling of animal waste in general.
Got it. What about managing other common problems? Nutrition is often a challenge.
Huge challenge. Weight loss or wasting can be due to decreased appetite, nausea, mouth sores from candida making it painful to eat, or diarrhea causing malabsorption.
So what's the nutritional approach?
Generally, a high-calorie, high-protein diet is recommended to combat wasting and support the immune system. Fat intake might need modification if diarrhea is an issue. Small, frequent meals can help. Good oral care is vital too.
You mentioned mouth sores. What helps with that?
Using soft toothbrushes. Rinsing the mouth frequently with sodium bicarbonate solution or plain saline can be soothing. Importantly, they should avoid alcohol-based mouthwashes, which can be really irritating and drying.
Okay. Pain is another common issue, especially that peripheral neuropathy.
Yes, management needs a multimodal approach. Besides specific meds like NSAIDs or sometimes opioids for certain types of pain, drugs that work on nerve pain, like gabapentin or pregabalin, are often used for neuropathy.
What about non-drug approaches?
Definitely. Comfort measures like massage, applying heat or cold packs where appropriate. And a key nursing point is careful handling when moving patients, especially those who are frail or have joint pain. Use lift sheets, move them gently to avoid sharing forces on the skin or stressing painful joints.
Good point. And lastly, managing that chronic diarrhea.
Often, it's about symptom management with antidiarrheal medications. Dietary adjustments are also key, reducing roughage, maybe limiting fatty or spicy foods, avoiding caffeine and alcohol, which can stimulate the bowel.
And because of the diarrhea, skin care is important.
Critical. Frequent assessment of the perineal skin is needed to check for breakdown or secondary infection like candida. Gentle cleansing and applying barrier creams can help protect the skin.
Beyond the physical, the source also touches on psychosocial aspects.
Yes, it's crucial to assess mental status regularly, looking for signs of hand or depression. Assessing coping mechanisms, support systems. Providing confidentiality is essential, but also encouraging patients to plan for the future, like completing advanced directives and connecting them with support groups or mental health resources if needed.
So, wrapping up the management piece, it's clear that while HIV is complex, Effective CART has transformed it into a manageable chronic condition for many.
Absolutely. The focus now is on long-term health, preventing complications, maintaining quality of life, and the cornerstone remains that vigilant assessment for subtle signs of infection, and above all, promoting and supporting lifelong adherence to therapy.
Okay, let's end with a final thought, something sparked by the evidence-based practice section in the source material. It highlights that supervised physical activity programs seem to work better for people living with HIV. They have better adherence to exercise and improved function compared to just telling people to exercise on their own.
That's an interesting finding.
It is. So the question for us, perhaps, is how can we, as caregivers and maybe even system designers, better integrate structured, supervised wellness strategies like exercise programs, maybe nutrition counseling, into routine, long-term community care for people living with HIV? Could that help maximize not just viral suppression, but overall durable health and function?
That's definitely something to think about, moving beyond just the meds to more holistic, supportive, long-term wellness models. We wish you the best in your continued learning.
Thank you for joining us for this deep dive into HIV/AIDS based on our source material. We hope walking through the pathophysiology, risks, care, and management has provided a clear framework for you.